take something like lean meat poultry, some sort of cottage cheese, beans, soya bean, and other products, and you got oil and fat, all there to plan. How to plan? The planning need actually the glycemic index. Again, it's a science that need multiple disciplinary approach, जैसे कि डॉक्टर साहब ने अपने लेक्चर में फूड की मैनेजमेंट में कहा. Similarly, if you got something to not to give, what are those things? Table sugar with either white or brown, गुड़ भी include है. Number 2, honey, fizzy drinks. All these things are to be avoided for patients who are being picked up as GDM or who are already diabetic, or they are being picked up first time during pregnancy. These are the smart platter that has been there in SOGP guideline. Similarly, has been a concept of thali with half of the plate filled with a vegetable and few of the servings that are being added with the dairy and fruits, and one-fourth of thali containing proteins and starch and grains. So these are the concepts that are there as a general concepts. The tailor-made exercise, if there is no obstetric or medical contraindication, what it could be? Absolute contraindication, I'm not going to go into detail, and there are relative contraindications which makes a type of exercise. Because exercise is a part of the management of diabetes, but these are the special population. We need to have these consideration before putting them into real-term exercise. Then glycemic index, already gone. Glucose level cutoff. What ACOG and ADA guidelines give us the cutoff? The ACOG and ADA give us fasting of more than 95 should be avoided. Take to start insulin. Agar nahi hai, then 1 hour it should be around 140, that should be managed with insulin. And then 2 hours, if it is more than 120, it need to be managed with insulin. What are the targets to be set? Fasting should be less than 95. 1 hour post glucose or post meal should be less than 140. And 2 hours should be between less than 115, or some authority stays with less than 120 milligram per deciliter of sugar. Then what are the profiles of insulin which are safe? You can see there are different types of insulin. We all familiar with regular insulin. Then there are other helping insulin, better profile than the regular insulin, Aspart and Lispro, which are ultra short acting and give you less exposure to hypoglycemia and exposure to increased weight during pregnancy treated with insulin. And we know that the long acting insulin, we are familiar with the NPH, but there are other two like Detamir and insulin Duglidec, which are there to help us out. Then if you talk about regimes, there are different guidelines. Weight-based regime, trimester weight-based dosing, and then one dose for all regime. These are the different types of regime published in 2016 references. Not going to go in depth of that. Then if you talk about pharmacological management of gestational diabetes, हमने 3 में classify किया था शुरू में ही. GDM is characterized by increased risk of macrosomia and complications. So women with GDM in whom the glycemic targets have not been achieved with diet and lifestyle, pharmacological therapy should be started. पहली starting point क्या है? Insulin है या metformin है? Why metformin? Junior audience. Why metformin? Insulin treat what? Baby or the mother? Insulin treats baby or the mother, or both? It is actually treating mother and helps the baby. While the metformin treats mother or the baby? Both, because it crosses the placenta, it decreases the insulin resistance in the mother, and it also produces less exposure to hyperglycemia to the fetus, since it also crosses the placenta like glucose. So your first job for GDM, like patients with type 2 diabetes pre-gestational, it should be treated with metformin, lifestyle modification, and diet. And if not manage those levels fasting more than 95 if it is there, 1 hour more than 140, 2 hour more than 120, then insulin needed to be added. Please take this as a take home. ठीक है, आगे मैं अब इसमें से कुछ नहीं पढ़ूंगा, आगे चलते हैं. Pharmacological management of patients who are pre-existent type 1 diabetic. During pregnancy, the insulin requirement increase. We need to consider 28 weeks up to 32 weeks of gestation. As an average, you need to take around 0.8 units per kg per day in first trimester, 0.8 to 1 units per kg during second, and then 0.9 to 1.2 units per kg per day during the third trimester. So these are the three basic helping points. And then treat the pregnant women with type 1 with both basal and mealtime insulin, means MDDI treatment. There may be a question that people can use CGM and have got infusion pump, but since that facility is not universal, particularly in this particular part, we are not going to detail those at length. And thirdly, for women with type 1 diabetes who wants to use CGM, there are few things that are there, that is time in range concept, where the people need to see that the sugar all the time during pregnancy should not cross between this range, 63 to 140. So minimum should be 63, maximum should be 140, and this is how 70% plus reading should be in that range. And around 25 to 30% reading should be above and below. So these are the just loose guideline for managing type 1 diabetic. And then if you talk about type 2 diabetes, that is all existing or being picked up first during pregnancy, lifestyle type 2 diabetes is associated with obesity, lifestyle and dietary advice that should come, जैसे हमने पहले भी तस्करा किया. For women taking oral hypoglycemic agent other than metformin who are on GLP-1 injection, shift them to insulin and metformin prior to conception if happening occurs. Yani if you pick people prior to conception, then consider the use of metformin together with insulin, as this may help to reduce the total amount of insulin needed to be given. And then finally, if you talk about हाइपोग्लाइसीमिया ड्यूरिंग प्रेगनेंसी, ये वाहिद कॉम्प्लिकेशन है जो मैंने यहाँ पिक की है. बाकी जितनी कॉम्प्लिकेशन है मैंने कहा था अपने लेक्चर की बिगनिंग में, आई एम गिविंग यू एन ओवरव्यू. आई एम नॉट गोइंग टू गिव इनटू DKA मैनेजमेंट, not going to give you details of IUGR that is associated, post-pregnancy counseling, contraceptions. These are the things that are going to be covered tomorrow, inshallah, in the hall 2 by the gynecological and obstetrical champions tomorrow, my colleagues. So what is hypoglycemia? Any sugar below 60 milligram is taken as hypoglycemia. Hypoglycemia should be considered an individual with acute agitation, abnormal behavior, and impaired consciousness. There are two types of feature that we see in hypoglycemia, the adrenal-induced and cognitive symptoms, as we all aware of what is happening in patients who are non-pregnant even. उनमें भी यही होता है. And these signs do not usually occur. Take this note in pregnancy also, that the sugar goes below 45 at some time. तो बहुत ज़्यादा clinically diagnosed करना मुश्किल भी होता है, because features may be masked up to 45. Although the definition of hypoglycemia in pregnancy is less than a 60 milligram sugar. Finally, there are challenges in addressing in Southeast Asia. What are those? Lack of preconceptional screening, हमारे पास ये problem है. Maternal weight gain and postpartum weight retention. Lack of longitudinal care. Lack emphasis on medical nutritional therapy. Absence of national GDM guidelines, although there are some guidelines like SOGP guideline, MENA region guideline are there. Shabin Naz Masood, if present here, needs real salute from my side that they have already made that effort with the team, obviously. And then finally, I thank my audience. I think 10 minutes more. So sorry for that, particularly our senior colleague. And thank you.
Request Professor Dr. Amar Hussain Saab for his valuable comments.
Bismillahir Rahmanir Rahim. Assalamu alaikum. I would like to thank Professor Ahmed Shahzad and his team to arrange such a wonderful event. And it was a very important topic covered in this session, hyperglycemia in pregnancy. And the speaker did full justice with the topic. He very elaborately discussed all aspects of it, various complications, types, complications in the mother, complications in the fetus, and what targets are to be achieved and how they should be achieved. This is a big problem in this region now because we know that obesity is rampant, and as the obesity goes up, the diabetes is bound to go up, and we will be seeing more and more cases. So it is a need of the time that we educate ourselves with all these things. In the interest of time, I'll stop over here, and I think the obstetricians have something to say and add to it. Thank you.
Thank you, sir. Now I would like to request Dr. Sadiya Nazir Sahaba for his valuable comments.
Bismillahirrahmanirrahim. Thank you very much for inviting me in first international conference on diabetes. Presentation by Professor Karim Sahab. It is very elaborative, very nice presentation, and he enlightens us about the hyperglycemia in pregnancy. I would like to add some points. The prevalence of the diabetes has been rising worldwide in parallel with the epidemic of obesity, and we must counsel the patient in pre-pregnancy period, and the HbA1c level should be less than 6.5 because it is directly related with the anomalies in the fetus. And there is increased risk of GDM cases also, and about more than 50% patient of diabetes in pregnancy we have facing the daily routine, and we must perform GTT at 6 to 12 weeks because there is a 10-fold increase in the these GDM cases. They become type 2 diabetics. So annual screening, healthy lifestyle, dietary modification is must for the better maternal and the fetal outcome. Thank you.
Now I will request our guest from Saudi Arabia, Dr. Badal Mustafa, for his valuable comments.
بسم الله الرحمن الرحيم وأصلي وأسلم وأبارك على سيدي رسول الله. Thanks a lot for the invitation of the Lyallpur Federation and as well the other associated societies. Thanks a lot for the speaker for his very comprehensive overview. If I would really enlightened by the first wordings of Ar-Rahman, خلق الإنسان علمه البيان. Let us just raise one issue. What is my role after just listening to the great talk of the speaker? I guess being a photographer, being a prof, being a health alliant, being a nurse, being an IT people, we all can do. If there is one thing after my long, really modest 40 years of regular caring for diabetes in a pregnancy, I would tell one little statement: screen for risk of diabetes in teenager. You will be not surprised, I will not be surprised that I will detect many of the cases. They are not obese, but they are having higher risk. Apparently not. Apparently they have no patients at home with diabetes, but they are at higher risk we will see many of these cases. We have to approach them this early. Otherwise, we are just treating the tips, and will end us in nothing. Shukran.
Thank you, sir. Thank you very much. Now for the presentation of SHIELD, I would request Professor Dr. Tufail Saab and Professor Zahdi Yasin Hashmi Saab to present the SHIELD to our presenter, Professor Dr. Karim Kamruddin Saab. Sir, please. With this SHIELD presentation, we conclude our second presentation and first session.
Hello.
And after which second session will start. Thank you very much.
नहीं मैंने तो excuse me, State Secretary Dr. Ahmed Dr. Ahmed Shahzad, प्लीज़ मैंने एक कमेंट देना जी, मुझे इजाज़त है? अच्छा, मैं डॉक्टर समीना हकू जी, और मैं ये सोसाइटी ऑफ ऑब्स एंड गायनी की पाकिस्तान में जो रिकमेंडेशंस डिवाइस हुई थी, तो आई वाज वन ऑफ द मेंबर ऑफ द टीम. डॉक्टर कमरुद्दीन से तो मैं अभी बात कर रही थी. ही इज़ हस्बैंड ऑफ माय वेरी बेस्ट फ्रेंड फ़ारूक, एंड शी इज़ अ प्रोफेसर ऑफ गायनोकोलॉजी इन कराची. एंड I just wanted to say कि जो ये हमारी SOGP की गाइडलाइंस हैं, जैसे अभी आपने बताया कि 1 और 180 उन्होंने रिकमेंड की हुई है. आई थिंक इट इज़ अ लिटिल, उन्होंने इसको ज़्यादा ही कंसेशन दे दी है. ACOG की गाइडलाइंस को फॉलो करना चाहिए जो 1 आवर पे 140 है. और जो आपने एक फिगर बताया, आई लाइक्ड इट वेरी मच, कि ड्यूरिंग द होल प्रेगनेंसी द लेवल्स शुड नॉट गो बिलो 65 एंड इट शुड नॉट गो बियॉन्ड 140. इसको 145 कर लीजिए, लेकिन 145 के ऊपर कभी भी नहीं जाना चाहिए प्रेगनेंसी में. और हमारे पास इतनी अबॉर्शंस हैं, हमारे पास इतनी डायबिटीज़ इन प्रेगनेंसी है कि आपकी सोच से भी बाहर है. और अकॉर्डिंग टू अ सर्वे इन पाकिस्तान, 92% ऑफ GDMs दे गो अनडायग्नोज्ड. और 6 अबॉर्शंस के बाद और फर्स्ट ट्राइमेस्टर और सेकंड ट्राइमेस्टर एक्सपल्शंस के बाद जब वो आती हैं और वो बेचारी बिल्कुल फिर वो GDM से वो नॉर्मली डायबिटिक हो चुकी होती हैं, और फिर उनको एक बच्चा दिलाना बस बहुत ही मुश्किल हो जाता है. सो नॉर्मल फिजिशियन के पास, जनरल फिजिशियन के पास जब वो आती हैं तो बहुत आंखें खुली रखिए फॉर GDM. इट्स वेरी वेरी प्रेवलेंट नाउ. थैंक यू वेरी मच.
Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon, everyone. I am Dr. Muiza Shehzad, a dental house officer with keen interest in the interaction of diabetes and oral health. I am eager to explore collaborative approaches to patient management with all of you. It's a privilege to be a part of this remarkable national conference dedicated to diabetes care under platform of PCDA and LDF in collaboration of FMU, PSIM, PKNC, and PAFP. It's an honor to moderate today's session on this vital topic where we'll explore the significant role that oral hygiene plays in effective management of diabetes. As we know, diabetes not only affects the blood sugar levels, but it also has widespread effects on many aspects of oral health. Poor oral hygiene can complicate diabetes management, while good oral hygiene practices can improve the outcomes. This session will shed light on this critical topic. Ladies and gentlemen, it is my privilege to introduce our esteemed panel of experts who will be sharing their insights with us today. Joining us, we have three distinguished professors of medicine, Dr. Masood Javed, Dr. Badr Bashir, Dr. Masood Ahmed, whose contributions to both research and clinical practice have helped shape the landscape of modern healthcare. We are honored to have with us an accomplished gastroenterologist, Dr. Mughis Athar, whose expertise impacts on diabetes on gastrointestinal health.